It's summer. Time for sun, sand, and a potential COVID surge. Some brand new variants have entered the chat that are expected to drive a summer spike in COVID cases. So let's dive into the details. From Texas Public Radio, this is Petrie Dish. I'm Bonnie Petrie.
Support for Petrie Dish is made possible by UT Health San Antonio, committed to transforming the health of the community through the team that tackles problems from every angle, doing everything it takes to bring each patient the best possible outcomes. From teaching tomorrow's healthcare leaders to translating research into new treatments, UT Health San Antonio strives to make lives better. Learn more at groundbreakingresearch.org.
You may have heard that COVID is over. But if you are a regular listener to Petrie Dish, you know that simply isn't true. The declaration of a COVID emergency expired more than a year ago, yes, but the pandemic is still simmering and may heat up again over the next couple of months. See, we have some new variants that seem to have figured out a way around any lingering immunity you may have from your last booster or possibly even a recent infection. I had a JN1 infection in February. So I asked Dr. Jason Bowling, a professor and infectious diseases specialist at UT Health San Antonio and hospital epidemiologist at University Health in San Antonio, to bring us up to speed on these new variants.
Yeah, so what we're looking at now are basically new variants. They're calling FLiRT variants. They're offshoots of JN.1. And JN.1 was the predominant strain, and that was a shift away from the XBB variants that we were dealing with before. And it's important because the XBB variant lineage was what was used in the current COVID vaccine. So we're dealing now with these JN.1 variants, and so the offshoots are FLiRT variants. So FLiRT stands for two distinct mutations, and so it's an F for an L and an R for a T. And these two mutations in these new KP.3, KP.2, KP.1 have led to them becoming the new top variants. And it's thought that maybe these mutations allow them to evade the immune system evasion, and that's why they may be a little bit more transmissible, and what might be driving this increased activity that we're starting to see.
Yeah, because the FLiRTs moved up the charts with a bullet over the last couple of weeks. So for the 2 weeks ending on June 8th, KP3 made up 25% of new cases, KP2 made up another 22%, and KP1 was another 7 or 8%.
Yeah, so we know that by how fast it's kind of become the predominant strain, that it's very transmissible. There haven't been reports that I'm aware of that it causes any new symptoms or more severe symptoms, which is good. But as we know, the SARS-CoV-2 virus has really shifted from being more severe infections to more transmissible. That's probably both virulence, but also our overall underlying immune recognition of SARS-CoV-2, but it definitely appears to be very transmissible. And so I think people are at risk, particularly in the context of people not having received recent vaccines. A lot of people didn't get the boosters, and that fact that most recent vaccine that was available was slightly different in the strain that was selected.
Right. The most recent vaccine was a booster targeting the XBB variant, and XBB and the FLiRTs are all descendants of the old Omicron variant, but the FLiRT variants are not descendants of XBB. They're more like cousins a couple of times removed. Their parent is the last dominant Omicron subvariant, which is JN1. We'll talk about what that means for the old XBB booster in a couple of minutes. But first, since the FLiRTs belong to the JN1 sublineage, I got to ask this personal question. Since I did have a JN1 infection back in February, will that protect me from KP1, 2, and 3?
Yeah, so there is some protection once people have had it. There's always going to be variability, right? So it's a spectrum, right? We have some people that have it, and then especially if you're young, healthy, Your immune system might be robust to where you're protected for a longer period of time than someone that, has other immune issues, medical problems, older. So there's definitely a varied response. The good news is that we're seeing less severe cases overall, even when people get reinfected, which is good news. So there is some protection there. I think the vaccine helps to boost that still. And really what it does is blunt the severity rather than, prevent another infection. And so that might be what we're having to look at is, can we kind of at least keep people from having more severe disease or more prolonged disease?
Okay, so I want to stop you there because, yes, we are seeing less severe cases overall, but I don't want folks to come away from this podcast thinking COVID is now, no more than a cold. There are plenty of people out there that will tell you that it's just a cold and they're not credible, right? I want people to get the truth here, which is COVID can still make you very sick. It can put you in the hospital. It can still kill you. It can leave you with a number of post-COVID infection health challenges also that can last for years. It's not a cold.
No, it's not. That's right. And I think people we quickly have moved. We're treating this in some ways like we treat influenza, right? And so some people die from it. Some people get really sick. And we still see that with COVID too. So it is important for people to recognize that it still poses a threat.
And just because you didn't get seriously ill or die from your first infection or your second infection or didn't develop long COVID, that doesn't mean that you'll have the same response to your next infection. So let me tell you this. More than 73,000 Americans died of COVID last year in 2023. Tens of thousands have died so far this year. COVID is not yet and may never be something we can take lightly. Which reminds me of something that I've talked about a couple of times on this show, Paxlovid. Not enough people seem to be taking it when they get infected, including people who are at risk for severe disease. Now, that may be in part because there was a lot of talk last year about what was referred to as Paxlovid rebound. You'd get well and you'd test negative and then you'd get sick again and you could even start testing positive again. But I recently learned that COVID rebound is not really linked to Paxlovid. Anyone can have a COVID rebound, which I think is important information.
Right. So I think this is a really interesting thing, and I think it would be more in the news if there wasn't such COVID fatigue overall, right? So, initially when we heard about COVID rebound, part of it was when we were still learning a lot about COVID. And then part of it was we were really studying people that were taking Paxlovid, right? This nirmatrelvir, ritonavir, trade name Paxlovid, for treating it. And when you start a new medicine, you watch really closely to see what happens with people that take it. And what they saw in some of the patients that took it, and there was different estimates, maybe 1%, 2%, and then maybe higher, it was unclear, is they would take the medicine, they would start to feel better, and then a few days later, they would have new symptoms develop. 3 to 7 days after feeling better again, they would start to have mild symptoms, but symptoms nonetheless that were similar to COVID. And we saw that they were again testing antigen positive, which really reflects a higher viral load they could potentially transmit to other people. So a lot of that news got out there. And with that, the concern was from a lot of people, should I take Paxlovid if I'm going to have rebound? So the CDC has really looked into that because Paxlovid is not being used enough in people that really could benefit from it. And so they've looked at a lot of the information, and what they've seen now that we have more data, and there's several retrospective studies, but even one randomized control trial, is that actually people that haven't taken Paxlovid can also have rebound. So they can also have this where their symptoms get better, their viral load goes down, and then 3 to 7 days after that resolves, it comes back up again and they start having symptoms, and then again they test positive on an antigen test or have a higher viral load. So then that gets to the question, like, what's causing that, right? That part is not entirely clear.
So it could be something like a person's initial immune response knocks the virus way down, so they think they're all better, but then the virus is, just sort of unconscious, not out. So when the initial immune response wanes, the virus comes roaring back.
Yeah, absolutely. So our immune system is very sophisticated, and we have basically an early warning system where when there's an insult or an infectious threat, it sends out the early warning system to try and tamp it down. But then it tries to bring on the longer acting immune system, so it starts getting trained up to prevent future threats. And so, yes, it very well may be some of this interaction between our initial response and our long-term response that leads to some of this rebound effect that we still need to learn more about.
And I just read about a COVID preventative treatment available for immunocompromised people who can't get the vaccine. So what can you tell me about that?
Sure. So that is another monoclonal antibody. So remember back, it wasn't that long ago, but COVID time, it's all relative. But before we had Paxlovid, these oral pills, we were really relying on these monoclonal antibodies, and they would be available to give people to try and keep them. Most of them were for people that had early signs of illness. And so they would take it as soon as they got sick to try and blunt how severe their illness was or keep them from getting really sick. And then we had, for a while, Evusheld, which is the trade name for a monoclonal that was used to provide pre-exposure prophylaxis, so to protect you. So you'd have antibodies that would last for a while so that if you got exposed, you wouldn't get sick. And it was really for people that weren't expected to respond to the vaccine. Unfortunately, we lost Evusheld because of these shifts in variants, as we've been talking about, and we haven't had one for a while. And part of it's because the pharmaceutical companies have a hard time getting excited about investing in a monoclonal when it might go away with shifts in what we know is going to happen, shifts in the variants, right? Fortunately, we do now have this Pemgarda, which is the trade name for a new monoclonal, which apparently has higher levels of antibody in it and provides, again, pre-exposure prophylaxis, so protection before you get exposed to try and prevent you from getting sick. And then, again, it's for severely immunocompromised people.
That is great news. All right, let's talk about some of those hot button topics with another potential surge looming out there. And of course, I'm talking about testing, masking, and should you get another booster?
Yeah, I think that's a good question. I think a lot of people have already made the decision.
That's all on the way when Petrie Dish continues.
Support for Petrie Dish comes from Mama's Cafe, serving elevated comfort food, craft cocktails, and Texas beers on tap, 7 days a week. More information at mamascafesa.com.
Welcome back to Petrie Dish. I'm Bonnie Petrie. Back in February, I was exposed to COVID. I had symptoms and a negative rapid antigen test with a nasal swab. I knew I had COVID, and I'd heard that nasal swab tests were sometimes coming up negative for these Omicron variants when they shouldn't. So
let's give it a go. So down into the back of the throat.
I gave myself a throat swab.
And I'm all the way back there. And if you're not having a little gag, you're probably not in the right spot. I'm going to go to the other side.
And it was positive immediately. Tests have become kind of problematic recently. When you take one, you may not yet have enough virus in your nasal passages to get a positive result in the first days of your infection. So experts urge people who've been exposed and those with symptoms to test every other day until you have 3 negative tests. But COVID tests aren't cheap. You can't just order free tests online anymore. Add to that, COVID tests aren't fun, so a lot of people just aren't bothering. I spoke with UT Health San Antonio infectious diseases doctor Jason Bowling about this.
Yeah, so I think you pointed out a lot of the important parts. People are not really testing for the reasons you mentioned. One, access, right? It is expensive. And then there's the challenge that the tests that you can do at home, which are more convenient, can be negative up front. And this, when I even look at larger groups of people, it's definitely a phenomenon where you can have symptoms, and even if you do the test appropriately, it may be negative, and so you're supposed to repeat the test later, which is, that becomes more challenging. You add another layer of complication. And then you're right, sometimes depending on what site you test, it might cause some variability in how good the positive predictive value of that test is as well. So I think a lot of people have thrown their hands in the air.
And I get that. But if you think you might have COVID and you don't want to spread it around, what do you do?
Right. I think that's where you need to be more careful, with understanding that if you have symptoms, if you're in an upper respiratory infection, COVID's still out there. So it could be COVID, it could be some other respiratory viruses. But whether you test or not, you really should be taking measures to try and prevent transmission to other people, particularly people like in your household, that are going to be the highest exposed, and particularly people that are at high risk for severe disease. So people that are older or have problems with their immune system or other medical challenges that might make them at higher risk for having more severe disease. So you're right to be cautious. Even if you do a home test and it's negative, if you're still having symptoms, you probably need to take precautions because it could still be COVID, or it could be another respiratory virus that other household contacts probably don't want.
Right, right. And if you really don't want to spread COVID or any other respiratory virus around, then of course masks are still going to be useful, no matter how taboo they become.
Wearing a mask can still protect two different ways. It can protect the wearer from other people, which is important to know for people that are at higher risk, people that want to wear a mask for protection if they're going into crowded settings, particularly if there's less ventilation. But it also can help reduce transmission to other people for somebody that's still shedding virus. And so that's important too. We know that if you're in a household and somebody else doesn't, it's not like 100% that the other person's going to get it. Secondary transmission rate can be impacted, and you can take some infection prevention measures in the house. And wearing a mask if you're having symptoms or getting over COVID is one way that you can help do your part to try and prevent that ongoing chain or cycle of transmission.
So I was reading an article about the FLiRT variants in the LA Times, and it included advice, of course, from the California Health Department, and that advises an infected person to wear a mask for 10 days. Is that good advice?
That is good advice. I mean, that's the conservative approach, and that's going to get you further past where you're still shedding virus, right? So I think that's the ideal state. I think getting people to wear it for at least as long as they're having symptoms and a couple days after might be more practical. If you tell people 10 days, maybe they'll wear it for 5. It's kind of what we tell people. I always worry when you have a medication that you get 3 times a day. We have data that shows that people might take it twice a day, right? So you worry when someone says take a medicine 4 times a day. No one's taking it 4 times a day. So I do think it's good advice. From a practical implication, that would get you further out and give you more protection for a longer period of time.
Okay, now the really hot button topic, vaccines. So it's a weird time for new variants to come along, right? Our last booster was targeted at XBB, and it came out last fall. And since then, JN1 became the dominant strain, which, as I mentioned earlier, is kind of a cousin to XBB, but not part of the same sublineage. And now the dominant strains are JN1 descendants, KP2 and 3, so they're even further away from XBB. Did you follow any of that? I hope so, because the next booster will target FLiRT variant KP2, but it won't be available for months. Okay, that brings us to my question. If you haven't had a booster since last year and you feel sort of naked going into a potential surge without more recent protection, should you even bother to get an XBB booster?
Yeah, I think that's a good question. I think a lot of people have already made the decision. The people that were interested in the vaccine got it, and then the people that didn't are probably going to be holding out, which is probably okay. They would release some guidance for people that are 65 and older to get another dose of the 23-24 of that XBB vaccine. But now we're getting closer to where, if you get that, are you going to impact your immune system response? If you're because September is like 3 months away, right? And so I think if people have waited this long, they might wait until they get the next one. It's kind of I would take it on an individual basis, what their thoughts and concerns are, what their real risk is, and they should have probably a conversation with their doctor about it.
All right, sometimes lost in the conversation is Novavax, the protein-based COVID vaccine, and that's going to be targeting its next booster at JN1, not the FLiRT. But since the FLiRTs are subvariants of JN1, will it still be worthwhile to get a Novavax?
Yeah, so I don't think that's going to be a bad thing necessarily, right? JN.1 and the FLiRT variants are still fairly close, so it's thought that probably is going to be fine.
Okay, good to know. Before I let you go, I want to tell you about how I sometimes feel like I live in crazy town these days. I mean, it's happened a lot since the pandemic started, honestly, but lately I've noticed that people who are sick with a cough and respiratory symptoms, sore throat, all the symptoms of COVID at a time when there's an uptick in COVID cases, they'll say, man, I am so sick. I've got some kind of mystery illness. I can't even imagine what it could be. And they say, I guess it's the flu in June. So they don't mention COVID at all. And it really makes me nuts. I mean, there's really not a lot of flu around. There is COVID around right now. So why do you think people are so reluctant to consider or mention or sometimes even think about COVID? I mean, it's weird, right?
Yeah, that's a great question. some of this, it must just be like a human reaction to like tragedy to this and stress. And we try to basically minimize it. I think the psychologists would be able to more eloquently describe this phenomena, but there's definitely this phenomena of people just wanting to move past it and act like it's no longer an issue, but it's still a real threat. And I think we need to just get through these 5 stages of grief, really to acceptance, right? And figure out how do we cope with it in a healthy way so that we're doing the right things to protect ourselves when we need to, but figuring out a way that we recognize it as well. It doesn't cause undue stress or alarm, but we're not completely minimizing it either.
Yes, that's where I hope to get, and I hope this episode helps. Thank you for your help with that, Dr. Jason Bowling, and for giving us the scoop on the current state of COVID. This episode of Petrie Dish was produced by TPR Vice President of News, Dan Katz, Jacob Rosati, and me. Jacob composed all the music and created the sound design. Petrie Dish is a production of Texas Public Radio. I'm Bonnie Petrie. Talk to you soon.